Well, hello everyone. It's 12:30. Welcome to Friday's report out. Hello, my name is Julian. I'm Julian Hartley, Chief Executive, Leeds Teaching Hospitals. It's a real pleasure to welcome you as usual to Friday's report out. We've got two great report outs for you today. We've got Mikey Ewens, who's going to be talking to us about reducing errors in sexual health samples. Really good QI project, and also our MMPS team on inpatient nurse ordering. So we're going to start with you, I think, Mikey. Welcome. Really looking forward to hearing an update on your QI project. So over to you.
Hi, I'm Mikey Ewens. So thanks for the introduction, Julian. I'm presenting or reporting out about a quality improvement project at Leeds Sexual Health. So I'm the Chief Registrar for the Trust and a Registrar in Sexual Health and HIV. And this was a project that I initially reported out on about 12 months ago that was looking at how we reduced errors in sexual health samples across our sexual health services. Next slide, please. So this is a statistical process control chart that is basically just outlining that at the beginning of last year, 2019, we had great sort of variability in the number of rejected samples per week from our Leeds sexual health sites, and it averaged out at about 24 rejected sexual health samples per week. Next slide, please. And when we looked at this in a bit more detail, we decided to look at about 6 to 7 months of data where we had just shy of about 20,000 people coming through our service. And we had 600 rejected samples as reported through our telepath system. And that equated to about 2.5% of our patients coming through clinic. So roughly about 500 patients were affected because more than one sample may have been rejected for the same patient. And when we thought of that another way, we had walk-in and wait clinics that are basically where people come in with symptoms and wait to be seen, and they averaged at about 50 patients per day. So when we were presenting this to the service, this potentially could have been looked at about, on average, for every patient we saw for 2 weeks who was symptomatic, who got up out of bed and queued to be seen at the Marion Centre. Every one of those patients had a rejected sample and would need to be seen in clinic again. So obviously large capacity issues there. Next slide, please. So when we looked at Pareto Analysis, this is a way of looking at data to see how you get your biggest wins. So we stratified all of the rejected samples, and what we found was that 20% of the problem, 20% of the issues caused 80% of the problem. So the majority were labelling and leaked samples. Next slide, please. And so when we looked at this in great detail, we found that about 70% of people that had a leaked sample needed to come back into clinic, okay? But 30% of those would probably result in a DNA. Next slide, please. Next point, please. And next point, please. And interestingly, about 1/3 of people would have a missed opportunity to test. And this is really important in Leeds because we live in a high prevalence area of HIV. So it's important that we screen people for HIV and syphilis and other bloodborne viruses at any point of contact with services, with healthcare services, but particularly sexual health services. And this is really important because the rates of syphilis are the highest since record began. And similarly, with the advent of new HIV reduction techniques, it's really important that we get the correct test done at the correct time. Next slide, please. So this slide shows that actually the majority of samples were rejected from our hub site at the Marion Centre, which is pretty self-explanatory because that's where the majority of our patients go, and that the problem of mislabeling and leak samples was across the board. It was not just one health professional. We were all sort of having trouble with the patients that we saw and the samples that we were processing on their behalf. Next slide, please. So we created, in collaboration with our healthcare assistants, an aim to try and reduce the number of rejected microbiology samples from Leeds Sexual Health within 4 months. We wanted to reduce the number of error by 80%. Next slide, please. And we did this through plan, do, study, act cycles. So we used the Institute for Healthcare Improvement model for improvement. So we were testing small ideas of change and then trying to spread those throughout the service. So on the 2nd of September 2019, with our healthcare assistants, we mapped our process out and we introduced a second check stamp of all of our microbiology samples leaving the Merion Centre. On the 14th of October, we shared data from our introduction of the second check stamp and our improvement. So we actually had a team celebration event and a breakfast and shared the success that we reaped from that first PDSA cycle. And then in the 30th of December 2019, we upscaled our second check stamp to all 4 of our sites. Next slide, please. So again, this is quite a busy slide in terms of statistical process control charts, but the numbers at the top show when our plan, do, study, act cycles were implemented in succession. And so it shows even when we first engage the healthcare assistants in terms of trying to improve the project, just highlighting the fact that something bad was going on with our samples led to a statistically significant improvement over the following 7 weeks. So we know that it went from about 24 rejected samples per week to about 21. And then at the start of PDSA1, you can see that there's a significant change from that baseline mean, that line that joins the dots up, to about 10 per week. Next slide, please. And what we did realise is that sort of by December time, we did reach our 80% improvement. We've gone to about 4 rejected samples per week, which was an incredible achievement from the team. Next slide, please. And here's just a little bit more data to show how we've been going on throughout the whole process and how we've really tried to embed the change and success within our team. So our baseline was just under 21 rejected samples per week. After the introduction of PDSA 1 and 2, we obviously had a stepwise improvement of about 50%. And as you can see along the bottom, as time goes on after the introduction of PDSA 3, we increased our improvement to about 76%. Now that black box in mid-October that shows we had 80% improvement, that was statistically significant, was actually correct. Now the issue with statistical process control chart is that it continually recalculates your mean improvement. So actually at step 2, as weeks progressed, we continued to be at 80%, but as new data was added, it sort of dropped slightly to 76%. And then as you can see into 2020, we had a further stepwise improvement of 90% improvement, so 2.2 rejected samples per week, obviously affecting a much lower number of patients than previously in sort of June, July time. Next slide, please. And then again, this shows throughout 2020 to 21, with the pressure on our labs within sort of LTHT and the redeployment of our healthcare and nursing staff within Leeds Sexual Health, how we have still managed to keep some improvement going on board. So as you can see in sort of May, June time, that's when our staff were redeployed. And you can see that there was a slight reduction in our improvement to 53%, but we didn't manage to maintain that for a number of months. At this time, our labs were rapidly progressing with COVID-19 testing, and the PCR lab is the lab that sort of processes our chlamydia and gonorrhea testing. So as you can appreciate, they were really, really busy at that time, and sometimes they were having to batch our chlamydia gonorrhea samples, and therefore there could have been errors with transport and labelling if there was a delay in processing that sample. And then when our staff were redeployed back into our service and the second check sample was more scrupulously followed, should we say, we managed to maintain our improvement to 80% at step 5, and that continues to today. Next slide, please. So I think, this was a massive success for our service. As a result of this quality improvement project since implementation over the last 18 months, Leeds Sexual Health have achieved, next slide please, 832 less repeat attendances to our service as a result of this project, 260 less DNAs, and the next point please, 340 less missed opportunities to test, and that's really important in a city where the rates of sexually transmitted infections are still quite high. Next slide, please. So thank you for listening to me. I hope you found that useful. It's been a joy to sort of oversee this project throughout my clinical leadership fellow year and into my chief reg year. There are lots and lots of people I want to thank as a result of this project. So obviously the partnership board at LCH and LTHT, the lab at LTHT, and all the wonderful staff at Leeds Sexual Health that have really got on board and really enjoyed participating in this quality improvement project.
Great. Mikey, that's brilliant work. Thank you so much. And some really interesting data there, and actually some quite surprising issues. Particularly, I was struck by what the point you made about syphilis incidents and so on. And but really, really good work. I'm sure there'll be lots of questions for you, but if we can hold those for now, because we're going to move on to the next report out, and we've got the medicines management and pharmacy services team on the inpatient nurse ordering service. So over to you guys.
Thank you very much, Julian, and just wow, what a report out. Thank you, Michael. That's a very hard act to follow. Really impressive work. So hello everybody, my name is Matthew Spence. I'm a pharmacy technician. I'm also the department's continuous improvement specialist, and we're here to talk to you today about our inpatient ordering piece of improvement work, which we came and reported out on in late October about our PDSA work that we'd been doing with J91. And I can see Debbie's on the call. It's great to see you, Debbie. We'll be giving you a bit of an update on how it's going on 91. And we were asked and challenged really about the scale and spread of this work. And that's what we're here to talk about today. Give you a bit of an update on the current state, what's working well, what are our challenges, what will we do differently if we were to restart this process again. Next slide, please. So before we go into the detail of that particular work, I just wanted to share with you how we've structured our improvement work within pharmacy. So we currently have our high-level value stream, which is our help Harry medicines management value stream, and then underneath that we've got 5 pieces of value stream work which are currently in progress, or 2 of them are currently paused due to a couple of reasons. Next slide, please. So this is a bit more detail of our high-level value stream map, and I wanted to share this with you because our high-level value stream map is around the missed doses of medicines and the ordering of missed dose medicines. So particularly what we'll call and refer to as the M4D4, which is the way medicines are recorded on eMeds when a missed dose is recorded due to no supply available. And one of our targets within MMPS is to have 0 M4D4. So we want all the medicines to be, the appropriate medicines to be on the ward before the patient needs them. And this particular value stream that we're going to talk about today looks at the ordering. And you can see where the 2 arrows where we can see our value stream boundaries, and actually our boundaries have extended. And we're going to talk about that because that's been one of the real challenges around improving this work. Next slide, please. So as I've mentioned, we're talking about value stream 2 within MMPS, and that's on inpatient ordering. And our vision for this is around to make the ordering of inpatient medicines quicker, slicker, less frustrating, and in enabling nursing and pharmacy colleagues time to focus on other areas of patient care. For those of you who saw our report out in October, we did a large piece of engagement work, and there was a lot of frustration, and we focused on J91, and we had a really great collaboration on there, and we managed to implement an improvement where the nurses are now ordering electronically via eMeds. So there's no paper in the process. It's in flow, and it's had some really significant impact on our processes. One of which is, from a nurse's perspective, it's 71% quicker to order medicines, and from a pharmacist's perspective, it's also 41% quicker for our team to order medicines. So it's made a significant impact, and we'll talk a bit more about some of the benefits. Next slide, please. What we also developed was a new process around newly prescribed medicines, and I wanted to share this because this is where our boundaries have extended, and this has been one of our challenges, because what we recognized was that although nurse ordering on eMeds was making a difference, it wasn't resolving as many M4D4s as we would hope. So we actually implemented a new process where our pharmacy team are being proactive in ordering. The doctor prescribes a medicine. We are then ordering that medicine before the actual medicine dose is due. So there's no nurse intervention. It's completely doctor, pharmacy onto the ward. So one of the benefits around this is that we found that the morale has been better, felt better about the ordering process. The time for medicines arriving into the dispensary has improved, and there's been a reduction in duplicate orders hitting the dispensary, which has had a significant impact. Next slide, please. So Debbie, I don't think has seen this slide. This is the latest hot off the press data on the improvement PDSA work that we've done on 91. And as I say, one of the key drivers for us is the M4D4. So medicines not available due to not given because the dose is not available on the ward. And since we've started our improvement work on 91, we've seen a 77% improvement in reduction of M4D4s recorded, and this is sustained over a number of months, and we're actually 1 point away, or 1 month away, hopefully, from a step change, which is absolutely fantastic. Great credit to 91. I take my hat off to them. Next slide, please. What this slide shows is the actual overall trust view of M4D4s, and unfortunately we're seeing a different picture from the one that we're seeing on 91, and there's numerous reasons for that, which I'm not going to go into today, but actually what we will hopefully see is, as we roll this further out and scale and spread this across the trust, is that our M4D4 rate will drop. I'm now going to hand over to Jen. Next slide, please.
Thanks, Matt. Hi, everyone. My name's Jen. I'm one of the pharmacists working on the team. And as Matt's already said, so one of our quality metrics is the rates of M4D4. And during our scale and spread of this from 91, we did a cohort of wards within AMS around December time, and this graph shows the data to reflect that. And as you can see, some wards are doing really well, and the idea is that the red bar is lower than the blue bar, because blue represents M4D4 rates in February 2020, and the red is February 2021. Next slide, please. And this is the second lot of AMS wards that we rolled out to only in early February. So as you can see, there's a little bit more work that needs to be done here, but we have come across quite a few challenges in the last couple of weeks, and I think it's taken rolling out to these wards for us to recognise those, and actually how much it affects the process, which we'll talk about later. I'll now hand over to Keely, who will talk about developments at LGI. Thank you.
Next slide, please. Hi everyone, my name's Keely. I'm one of the pharmacists working on the project over at the LGI. So we introduced a pilot onto Ward 15 about 3 weeks ago, and we were lucky because we were able to learn from the implementation within AMS on what was important for the success of the project. So staff engagement was really important, and what we did when we introduced it to Ward 15 was we made sure that we had 2 nurses who were champions for the project, as well as 2 pharmacy technicians as well, and the results show that there's a positive outcome already on Ward 15. Next slide, please. We have been looking at a morale focus metric as well in terms of the results for this project, and we've been doing this by completing emotional touchpoint surveys pre-implementation and post-implementation. So on the screen you can see the slides, the results for J83 over at, in AMS. So pre-implementation, you can see that most of the responses to how nurses felt about ordering medicines from pharmacy was either neutral or negative. And then post-implementation, you can see that we had a number more responses, but 100% of the responses were positive as well. We have got some direct quotes from nurses, and they feel that the new way of ordering medicines using eMeds is great, and the improvement is a more effective delivery between pharmacy and the wards. So I'm going to hand over to Emma. Next slide, please.
Good afternoon, my name's Emma Horton, I'm the lead nurse in MMPS. So, next steps, we absolutely recognise that we need to scale this up and spread it far and wide so that the rest of the organisation can have the benefits that AMS have been having. But before we do that, we really recognise that as we did spread within AMS, that some issues came up that we absolutely need to unpick and resolve. A lot of these are technical before we move them on. So we have a little group looking at MedChart and speaking with the supplier to see what are the next steps forward in relation to the ordering. We also are in the process within pharmacy, within our own team, to develop robust MMPS services to manage this service, this process, because it's a real change in the ask. We've been doing, but prior to doing all this work, how medicines were ordered hadn't changed in a huge number of years, and we need to take people along on that journey. So there's a piece of work around there, but also with our nursing colleagues on the wards, because we want nurses now to order medicines 24 to 48 hours in advance. So we never need, so medicines never run out, that we are taking control of our and supporting our patients with their medicines. We want to standardise this work. So regardless of what ward you work on, everybody's clear on how we order medicines. And we want us to have key messages so that we're not setting up staff to fail, we're actually setting them up for success. During this period where we've just paused it, we're continuing to do PDSA because we're looking at where the waste states are and seeing if we can improve those processes. So this little pause, it's ideal because it allows us to go back to the teams like J91 to share what we found out and how we can move this forward. Next slide, please. So, but in all of that, we have still got a structure and how we're going to support this rollout trust-wide. So within pharmacy, our teams are set up slightly different to how they are with the CSUs, but we've spoken to our colleagues clinically, and we are going to, this is our rollout plan. We see it CSU by CSU, and we are going to be brave and do more than one CSU at a time. But in order to support these wards and clinical areas, we've got roles and objectives. So we, as Keely mentioned when she rolled out to L15, we will have champions, and we want to support those staff. So when it hits those areas, they know how to answer those questions, and it just becomes embedded in those clinical areas. Next slide, please.
Thanks, Emma. So we'd just like to share what went well throughout our rollout within AMS. And also, as part of that process, we have communicated with other CSUs, and the enthusiasm for this project is great. The engagement from the nursing teams and the pharmacy teams is really good. And we've recognised that actually the power of data is really interesting and important. And based on our observations on J91 when we first piloted this, and some recent data in February, we've got rough estimates that we can potentially free up around 100 hours of nursing time to be used more effectively, and over 70 hours of pharmacy time, which is really positive. And also we've seen an unintended consequence from J91, and actually there's been 115% increase in their orders that are booked into pharmacy between the hours of 9 and 10 in the morning. So that shows that the work's getting done a lot quicker during the day or earlier in the day. And going out to the wards, asking the nurses what's going on, what's happened, the problems that they are coming across, has been really useful. And we've learned lots through this process, and just seeing people engage and grow as part of the process as well has been really good. Next slide, please. So a few challenges and barriers that we've come across. The scale and spread, obviously we'd like to scale and spread quicker, but obviously, as Emma's already mentioned, we have come across a few issues within the last few weeks, and behaviour change is a big challenge, because as Emma's already said, you know, we're trying to unpick years and years of old practice, and trying to get that changed is difficult. EMEDS issues, as Emma's already mentioned, communications across CSU improvement and moving forward, we could do that sooner. Regular ongoing engagement between pharmacy and the nursing team, so that's, as Keely and Emma have already mentioned about our ward champions, really starting that engagement before the process happens, I think is really, really important, and that's what we've noticed. Standard work to develop it to be done with the nursing teams, not just heavily pharmacy, so we're not doing it to them. And you know, we've recognised that sticking within boundaries is very difficult. There's lots of interdependencies with this work, and what goes on at ward level affects the processes that we have in pharmacy. So trying to separate it and not bring too much into it is quite difficult. Next slide, please. So what would we do differently? The speed of scale and spread, obviously we'd like to go quicker because the way that nursing teams work and they move around wards a lot, it's not ideal having one ward doing one process and another ward doing different things in terms of ordering their medicines. Develop a robust project plan earlier on, so we've got a defined time scale, and setting our staff up for success and getting the right people in the room early on, so getting all the champions together and explaining the process, building their confidence with it before they are needed to support the nursing teams. Next slide, please.
Great. That was tremendous. Thanks very much to the whole team. And actually, if you look in the comments, there's a whole series of comments that's worth a look in terms of people's reflections and congratulations and the impact that we've seen of this in our ward. So really good. Thank you. So we're up against it a bit time-wise, but I am going to allow some time for questions because we've had two cracking report outs there. So who'd like to kick us off? Una, I think I can see your hand.
Thank you. I just wanted, it's more of a comment just to say a huge thank you and well done. When you think about the time that you can save for our nursing colleagues at wards, that experience for patients will only improve. So that's my first comment. My second comment is just a thank you to the team for being really open and honest about the challenges that there are when you're doing improvement work, but they've shown real perseverance and real resilience. So I just want to commend them on that, Julian. I think they're fantastic. So well done, everybody.
Well said, Una. Particularly during the period that we've had over the last several months, and Mikey too. I think both report outs just show how improvement continues even under the severest of challenges. So it really is testimony to the teamwork and commitment and thirst for improvement. Well, really well done. Any other comments or questions before we wrap things up? Tony?
Hello everybody, my name's Tony Cronshaw. I'm a patient partner, so my role is to be outside eyes on these improvement initiatives. We've just heard two fantastic reports of incremental improvement, which demonstrates the efficacy of the Leeds improvement method. So I particularly want to congratulate both teams. I thought they were both fantastic examples of what it's possible to do, even in very difficult times. Specifically, though, with regard to the report out on the sexual health improvement work, it was really interesting to see the tangible impact of the redeployment which COVID. What was even more interesting was that having had staff repatriated to the service, it had been possible to get most of the way back to the previously established improvement level, but not all the way. The service was functioning at a 90% improvement, or roughly 90%, and has managed to re-establish 80%. So I just wondered if there were any projections or expectancies around how that would progress into the future.
Thanks, Tony. Mikey?
Yeah, thanks. It's really difficult, isn't it? Sort of projection-wise, we hope that we at least maintain. So we celebrated that we reached our aim, and again after sort of our staff coming back into service. I think recognising with our staff members that everyone is just exhausted at this moment in time, and celebrating our getting back to our aim has been really well received. Actually, I think it has improved morale very much. We've managed to sort of report this out in various sort of regional and national meetings. Hopefully we'll continue to improve. You know, we're on a massive improvement journey within Leeds Sexual Health with various different work streams. I think projection wise, we're hoping that as our new streams of quality improvement work continue, that this will further embed and improve our existing projects. We aim to just feed back monthly now rather than weekly, and hopefully it's just a case of touching base and making sure that our process is embedded. So hopefully not too much difference in the future, hopefully continue to improve, but you know, it's all a journey, isn't it? And just celebrating those wins where we can, hopefully will keep us going.
Thank you, Michael.
Great, thank you. Well, thanks very much, everyone. We'll close there, and just to say, I really appreciate everyone's commitment to continuing work on the Leeds improvement method. We've seen two shining examples of that today, and I'm also grateful for the KPO as ever who support this work and continue to ensure that we maintain and support everyone who's well into or just starting out on their improvement work. And as you can see from today's report out, the benefits for our patients, staff are really inestimable. So really well done. Thanks very much, everyone, and see you same time next week. Thanks very much. End of report out.